Donc, bonjour à toutes et à tous. Je m'appelle Marie-Claude Lépine, je suis responsable de secteur pour les laboratoires IKIN. Je travaille sur l'Île-de-France et les Hauts-de-France. Je suis ravie que vous puissiez vous connecter ce soir à ce deuxième webinaire sur l'impact psychologique du patient stomisé. Deirdre Cunningham, notre infirmière spécialiste dans le domaine à l'hôpital de Belfast, vous fera parvenir son expérience très enrichissante. Avant de commencer, je vous prie de vérifier que le son est bien activé sur votre ordinateur, qu'il n'y a pas de soucis techniques. Et si c'est le cas, merci de nous en faire part avec le chat. Ce webinaire sera enregistré. J'espère qu'il n'y a pas de soucis pour tout le monde. Vous pourrez poser des questions. Blanche, notre traductrice irlandaise, mais aussi toulousaine, se fera un plaisir de traduire vos questions afin que l'équipe puisse y répondre. Je suis accompagnée de Mary McCrogan, notre conseillère clinique, ainsi que Deirdre Cunningham, notre infirmière spécialiste dans le domaine. Je vais laisser la main à Mary et je vous souhaite un excellent webinaire. Mary, it's your turn.
Hi everyone, my name is Marie McGrogan and I'm the Clinical Advisor for TG Aiken. On behalf of Aiken, I would like to welcome you all and say a huge thank you for joining us today. We really do appreciate it, particularly during such challenging times. I recently produced a white paper focusing on the psychological impact of stoma-forming surgery. And during the research and development, it became quite evident that whilst there has been huge progression within the quality and efficacy of both products and services, it was also abundantly clear that the psychological impact of stoma formation continues to be a considerable issue for many patients. The studies consistently highlighted three main areas of concern. Firstly, the loss of control leading to a grieving process, then the altered body image with reduced self-esteem, and the importance and value of self-efficacy for our patients. And then the fear of intimacy resulting in psychosexual issues for many patients. And finally, as enhanced recovery is now embedded into clinical practice in many countries, stoma care nurses are under increasing pressure to prepare patients for earlier discharges, therefore reduce time spent on psychological support. Over the past decade, there's been a growing realisation that successful surgery is not dependent solely on the operation alone, but rather on how well the patient is able to return to a physically and psychologically healthy state. Enhanced recovery after surgery has been associated with a risk reduction in post-operative complications, shorter hospital stays, and no increase in readmission rates. There is also growing evidence supporting the introduction of prehabilitation, whereby interventions such as exercise, nutrition, and anxiety reduction in the preoperative period can complement the enhanced recovery programme and facilitate the return to baseline activities of daily living. So with this in mind, we are now embarking on our second webinar, which will explore how enhanced recovery after surgery improves patients' outcomes with this evidence-based pathway, but also provides a patient-centred approach, ensuring that patients feel supported throughout their surgical journey. So without further ado, I would like to introduce you to today's expert speaker, Deirdre Cunningham. Deirdre is an enhanced recovery nurse for the colorectal service in Belfast, Northern Ireland. She has 20 years experience in colorectal surgery, both within the NHS and in the independent sector in various roles: staff nurse, pre-assessment nurse, ward manager of colorectal surgical wards, and most recently setting up a formal colorectal enhanced recovery service within her hospital. Deirdre's presentation today is entitled Enhanced Recovery After Surgery, Improving Patient Experience and Surgical Outcomes. At the end of Deirdre's presentation, we will then move into a 15-minute Q&A session. So please feel free to enter any questions in the chat box throughout the presentation, and we will endeavour to answer when Deirdre has completed her presentation. On behalf of Aiken, I would like to say a massive thank you to you, Deirdre, for agreeing to present and share your wealth of experience today. Over to you, Deirdre.
Good afternoon. My name is Deirdre Cunningham and I'm a colorectal enhanced recovery nurse. I'm based in Belfast, Northern Ireland, and today I'm going to talk to you about enhanced recovery after surgery, improving patient experience and surgical outcomes. Enhanced recovery after surgery, or ERAS, is a patient-centered, evidence-based, multidisciplinary pathway and unit culture which aims to reduce patients' surgical stress response, optimize physiologic function, and facilitate recovery. In other words, it helps patients get better quicker after major surgery. And good compliance to an ERAS pathway improves short and long-term outcomes. So I'll explain a little bit about the role of the enhanced recovery nurse in my service. And of course, it's important to say that it's not going to be the same in every service or hospital. That needs to suit your own service and suit the needs of the service and the patients. So preoperative information giving to patients about their expected goals and discharge dates. And it's really important at this stage that patients are encouraged to take responsibility for their own recovery. But they also need to know why they're doing the interventions that we're encouraging them to do. So it's important to present the evidence to patients at this stage. We see patients daily while they're in hospital, and we encourage their daily goals towards discharge. We use a patient diary if it's appropriate, if the patient's going to respond to that and if it's going to be helpful for the patient. We provide telephone follow-up post-discharge. Patients are phoned twice after discharge, and they can phone the ERAS team at any time. And this isn't prescriptive. If patients need more support, we can give them extra phone calls. We collect data and enter that into our ERAS dashboard. Teach and support all staff across staff areas and exploring barriers to implementation, of which there are, I would imagine, in every service. Regular strategy meetings of the core team and updates to the larger team. We feedback data regarding, for example, compliance and length of stay. We liaise with our ERAS colleagues in the UK to benchmark our service and ensure that the latest evidence is incorporated into our practice, and provide strategic influence locally and regionally. So I'm going to go into a wee bit more detail of the interventions that we do in each area, starting with preoperative interventions. So information giving to patients, as mentioned earlier, is really, really important. The multidisciplinary team needs to really be giving the same information to the patients to manage expectations. It's not helpful to the patients or their recovery for people to be saying different things, even slight differences. So we need to make sure that that's consistent throughout the team. Stoma nurses see our patients face-to-face preoperatively in our hospital. They provide preoperative counselling and practice packs. I think it's important at this stage that patients are really encouraged to use their practice packs. We do notice the difference between patients who have, and I'm sure you do as well, patients who have actually used their practice packs at home. They seem to be more confident, they learn quicker while they're in hospital, and they get out a wee bit quicker. Pre-assessment and anaesthetic assessment if appropriate, and a surgery school if that's provided in your service or hospital. It's also important to give written information at this stage. We all know that patients who are seen in an outpatient setting, and probably our own experience as well, it's really difficult to remember everything that they have been told in one attendance. And in our hospital, the patients see the surgeon, they see the pre-assessment nurse, they see the stoma nurse, and they see the enhanced recovery nurse on the same day. So written information about their operation and also about post-operative expectations is really important to give patients at this stage. We need to be optimising their medical status. So patients who have iron deficiency anemia should be referred to an IV iron service. Or if there's time to optimise them with oral iron before their surgery, then to use oral iron. We need to improve patients' diabetes if they have diabetes, stop smoking as well, and reduce and stop alcohol safely at this stage. Prehabilitation is an ideal for lots of hospitals. Some hospitals have the facilities to have a prehab service. And I think that would probably be the ideal for most places if resources existed. So a facility where the patients could have a bespoke exercise program before their surgery, if it was appropriate. Obviously with colorectal surgery, with our cancers, we have a very short window of opportunity to improve patients' activity levels in order to improve their post-op outcomes. But for example, our patients who need long course chemoradiotherapy before surgery, they would be the ideal patients to use prehab with. We use carbohydrate drinks for most of our patients. This helps to reduce metabolic stress and improve outcomes post-op. And of course, we don't use these for diabetic patients or patients with a known gastric emptying disorder. The evidence isn't there just yet to use with these patients. Bowel preparation. The evidence is to minimise bowel preparation on its own. However, there's some evidence to suggest that bowel preparation used along with oral antibiotics can minimise anastomotic leak and surgical site infection. Not all hospitals are using this. We actually are, but we don't have enough data just at this stage to see whether it's actually having an effect. But systemic bowel preparation on its own, there is no evidence for its use. So ideally it should be minimised. Not used at all. Intraoperatively. So balanced IV fluids are really important. The word balanced is kind of key there. We call it goal-directed fluid therapy. In other words, the patients get only the amount of IV fluids that they need. So we used to give patients far too much IV fluid, and that does not help post-operative recovery. In fact, it can be detrimental to post-op recovery. So in our service, the anaesthetists use waveform monitors so they can detect when a patient needs a bolus of IV fluid. We look at minimising the use of opiates. So, for example, for our laparoscopic cases, patients get a single dose of intrathecal diamorphine. They have an IV lidocaine infusion, and we use non-steroidal anti-inflammatory medication unless it's contraindicated. And then post-operatively, obviously, we use very small doses of opiates, but we use the smallest dose that we can titrate easily. And obviously IV paracetamol, things like that. Laparoscopic technique, if possible, is ideal and facilitates recovery. And minimising drains and tubes. This is I think always a slightly controversial area for surgeons. It's still surgeon choice whether they use drains, particularly for low pelvic surgery, like abdominal perineal excision of rectum. Drains are still frequently used. The use of nasogastric tubes for elective surgery has not been in use for years, so I think in most services we wouldn't see that anymore. Temperature control is really important. We want our patients to be normothermic before and during, and obviously after their operation. This also improves their recovery. Post-operative nausea and vomiting prevention. In our own data, when we looked at it, we saw that a very high proportion of patients experience post-op nausea and vomiting. So that's a really easy thing to address with the use of several different antiemetics during the anaesthetic and post-operatively. And we use a regular regime post-op with rescue antiemetic on top of that if needed. Post-operative, what we want is the patient to return to normal as soon as possible, normal activities, and that includes eating and drinking. And we know that there's no evidence that fasting patients post-operatively now improves their outcomes. In fact, the quicker they can get back to eating and drinking normally, the better for the patient. So we encourage our patients to eat and drink normal diet. So no dietary exclusions, but in small portions after their operation. So really about 4 hours after surgery they can start eating, and they can drink as soon as they're awake and maintaining their own array. Low residue diets really are only indicated, as the evidence says, for patients with new ileostomies or patients with multiple anastomosis, which wouldn't be the standard patient. We like to stop IV fluids as soon as possible. So as soon as the patient is maintaining their own fluid intake, we can stop their IV fluids, whether that's the night of the operation, if they've had their surgery earlier on in the day, or the next morning, or early the next morning. We like to stop them as soon as possible. Multimodal opioid sparing analgesia, again, as previously discussed. Opioids, as we know, can impact on post-op ileus potentially. So we want to minimise the use of opioids after surgery. So we will use IV paracetamol for at least 24 hours. We'll use non-steroidal anti-inflammatory medication unless it's contraindicated. And we use IV lidocaine during surgery. Post-operatively, if there is a PACU or an HDU environment, then they can have their IV lidocaine infusion for a bit longer. If they're just going back to an ordinary surgical ward, then obviously that has to be stopped. And we use small doses of opioid, the ones with the most minimal side effect, in order to get a good result. In other words, the patient being able to get up and about and do their normal activities. Early mobilization is really important for patients in an enhanced recovery program, of course, all post-surgery. So ideally, we want them to get up and sit the evening of their operation. And obviously, this is one of the bigger challenges, I think, probably with enhanced recovery, with staffing levels the way they are, how the wards are resourced. So different services facilitate this differently. Whether they use nursing staff or extra physio staff, it can be different in every area. So up to sit the evening of surgery, walk if possible. And obviously, the sooner we take out their tubes and connections, the easier it is for them to get back to normal activities. We encourage them to dress in normal clothes as well. Obviously, something comfortable, loungewear, but try and get out of pyjamas as early as possible and feel normal and feel well. We want patients to feel sick or think that they're not well. They're having surgery and we're going to get them better. Reiterate their estimated date of discharge at every opportunity that you have talking to the patient. In other words, so you're going to be going home in 3 days. This is what we need to achieve before you go home. And the expectations from the whole team. So we need every person in the team to be saying the same thing, as we've said before. It only takes one person saying, oh, you could be in for 2 weeks after this operation, and the patient then their focus will change completely. So we need to keep the patient focused and feeling responsible for their own recovery. Post-operative and post-discharge follow-up is really important for these patients. If we're looking at early discharges, day 2 or 3 after laparoscopic surgery, then they need to be supported at home. So they need to be signposted to who to phone if they have any issues, and we need to be contacting them and doing thorough assessments of how they're getting on at home and picking up any problems early. So we use the term dreaming in the UK. So drinking, eating and mobilising. We try and keep it simple for nursing teams, really post-operatively. So enhanced recovery can become very complicated if you make it complicated, or you can keep it simple for people. So are they drinking? Are they eating? Are they mobilizing after surgery? So psychological support for stoma patients is obviously really, really important. We tend to become focused in hospitals on kind of a medical model, and it's easy to forget the psychological aspect. Although I think we do this instinctively as nursing teams. We know that we need to support our patients psychologically in order to support their recovery. So there's areas that we go into with psychological support, and this really starts as soon as the decision to treat information has been given to the patient from the surgeon. Face-to-face preoperative counselling from stoma nurses who give the patient literature. We ideally include relatives in counselling, although things are becoming a little bit more difficult in that area with COVID, but if close relatives is included in counselling, that can help support the patient as well. Their relative, their wife, their daughter, or whoever is going to be the one who will be supporting the patients closely, so they need to be included in the counselling as well. Practice packs given at this stage and opportunity for questions, of course. So I think it's important to reiterate, as I said before, the importance of using the practice pack at home. Some patients will be very reluctant to do this, and I think it's important to say that they're not. It's going to really help their recovery to use the practice pack. That will improve in confidence. They'll know better what to expect and what questions they have to ask. We offer them peer support if time allows before their operation, and of course with our cancer surgery sometimes that window of time can be very short, but if it's indicated by patient need as well, some people don't feel that it's going to help them to talk to somebody who have had a stoma, but some people do, so I think it's important to offer that to the patients. We do have clinical psychology support available for patients with extreme need. At present, of course, that's case by case and as time allows. Not all patients, in fact, very few patients will need clinical psychology, but certainly we are able to refer in to our clinical psychologist who will work with all members of the multidisciplinary team in order to support the patient going into their operation. Daily teaching and support by the stoma team. Present in our service and probably in lots of services. We don't have a weekend specialist service, but on our colorectal ward, all of our nursing team and our health care support workers are trained in stoma teaching. So they're the ones that do the weekend teaching with patients. And it's important to do that on a daily basis. If sometimes intensive teaching, like twice a day, might be necessary for patients as well to facilitate their recovery. And daily visit and support by an enhanced recovery nurse, again, in order to focus all aspects of post-op recovery and keep the patient focused on everything that they need to achieve before they go home. And that includes psychological support from enhanced recovery nurses as well. And post-operative referral to community stoma nurse for home visits. So obviously the patients are then supported at home psychologically and physically by a specialist stoma nurse. And we do post-discharge phone calls as well from the enhanced recovery team, as we talked about before. So that is a very thorough assessment in which we assess every system, patients' wounds, their bowel function. We also ask them how they're doing, importantly, how they're feeling. So we can pick up any issues at this stage and support them in their needs and their relatives as well. We often the patients put their phone on speaker so we can talk to everybody and answer any questions that they need answered. So a couple of things that patients have told us of their experience of the enhanced recovery pathway. One person said, "I don't even feel like I've had surgery." Someone else has said, "You provide a terrific service." and you're making a bad situation a lot better. Nobody wants an operation, so the more we can support patients psychologically and make them feel that they have somewhere to go, they have people to ask, then that is vital for a good recovery after surgery. So in summary then, psychological support is integral in an enhanced recovery pathway and is essential to a successful recovery. We all need to manage patients' expectations. All members of the team should be saying the same thing in order to maintain patient confidence and focus them on their recovery. Patients should have robust daily support, and it should be individualised to them. Not everybody will have the same needs, and we need to respect that. We need to involve relatives in all discussions about expectations, as they're the main support for our patients, and they can influence how the patient feels about their own recovery. They can be helpful, and if they're not supported as well, they can actually hold patients back sometimes in recovery. Patients should have robust post-discharge phone support and phone numbers that they can use if they have issues or concerns. They should know really what post-operative complications can occur after discharge and who to contact and what to do. This basically empowers our patients to be partners in their own recovery. And it's important to realise as well with enhanced recovery that one size doesn't fit all. Not all hospitals will feel that they need to or have the resources to implement every ERAS intervention. Whatever is introduced in services, it needs to be driven by the data. So it's important to know what your service needs. And that's everything today. And are there any questions? Thank you for listening.
Hi, Deirdre.
Hi, Marie.
Hi, listen, thank you so much for your presentation. It was so informative, and certainly there's no doubt it really helps us walk through that journey that patients obviously patients now go through in relation to the whole enhanced recovery pathway. So just a couple of questions that on the back of your presentation. You talked about the use of practice packs preoperatively, and I guess I just wanted to explore with you the importance of introducing practice packs and what they are within the UK. What exactly does that mean, and what's your thoughts on ensuring that these are actually used preoperatively?
Yeah, sure. Well, our patients are met at a face-to-face meeting with our stoma nurses before their operation, and they are given all the information about their surgery. And as part of that, with their literature, they're given a practice pack, which is a little stoma bag and a little plastic fake stoma that they can attach to their tummy and place the bag over. They can put a bit of water in the bag, and they're advised really that it's best to start using this as soon as possible, so they can feel and see what it's really like to have a stoma. Well, not what it's really like, but it gives them an idea of how to use the pouch, what it feels like to have one in their clothing and things like that. So our patients are really recommended to use a practice pack as soon as possible. I think we find in practice that the majority don't use the practice pack, and I guess that's one of our biggest challenges, is how we encourage patients to use that preoperatively. Certainly our stoma team and ourselves have noticed the patients that do use it. Yeah. Because they're more confident and they're more prepared psychologically, and they know what to expect from their stoma teaching, because they have literally their muscle memory, their hands have actually done the actions. They kind of know what it feels like under their clothing, so they know what to expect. So I guess that is one of our biggest challenges, is how do we make sure patients use practice packs.
Yeah. And in an ideal world, how how much would you like a patient to, you know, to come to grips with the practice pack? So, for example, would it be 2-3 weeks pre-operation, or, you know, what's your thoughts on that?
I genuinely think so. In my opinion, obviously, I don't have kind of our own data to back anything up, but in my opinion, I think it's vitally important for the patients at that stage to be using it every day, because that's what will happen in life after the operation, and they need to be encouraged to know that it will actually help them and support them to do this for themselves. And I guess that ties in with encouraging the patient to be their own director of their own recovery and take responsibility for their own recovery. And it's our responsibility, I think, to emphasize that to the patient, because we can tell them, look, we know patients are more confident, they feel more supported if they have done this before their operation. So we think you should do this too. And how can we help you?
Yeah, absolutely. Yeah. And you'd also talked about barriers to implementation, you know, within the whole enhanced recovery pathway. And in your opinion, what are the main barriers that you come up against?
Well, I think it's really difficult to get the whole team working together. I think that's really the main barrier, to not just for stoma care, but for implementation for enhanced recovery altogether. So it's really making sure that every person in the team has buy-in for the enhanced recovery program and is saying the same things to patients. So I'd say one of the main barriers is if we're not all saying the same things to patients, they're going to pick up on that immediately. So they're not going to have confidence in the whole team, and they're maybe not going to, if, for example, the stoma nurse says you must use the practice pack and the enhanced recovery nurse doesn't even mention the practice pack, or vice versa. The patient's not going to think that that's actually an important part of their recovery, a very important part of their recovery. So we all need to be singing from the same hymn sheet in that sense, and that includes the patient. The patient is the centre of the team. They need to feel that they're part of the team. They're not just an object that we're kind of operating on. It's up to them to kind of work with us and work with themselves as well. So I'd say that's one of the main barriers, and also that we don't have enough time sometimes before colorectal surgery. So we only have time maybe to see them once, but are there other things that we can do to have more contact with the patient before surgery rather than just one appointment? So I'd say that's a barrier as well.
Yeah. I mean, obviously, I've heard a lot of feedback now in relation to patients who've gone through a proper enhanced recovery program, and all the modalities have been introduced, and clearly, surgically, physically, they've done so much better than the historical sort of pathway. But for me, as a stoma care nurse, the concern is that if a patient is discharged now on, for example, day 3, day 4 post-surgery, because physically they're doing so well.
Yeah.
For me, it's, you know, what happens with that whole psychological recovery and support that historically stoma care nurses would have been able to address in the hospital setting.
Yeah.
And guess for me, it's, you know, how are you aware of how this is now being addressed?
I guess a major part for me, a major part of the enhanced recovery service is post-discharge. So in order to facilitate early discharge, we, as an enhanced recovery team, follow patients up at home very quickly after they're discharged, which wasn't part of wasn't part of the surgical service prior to kind of enhanced recovery. Patients were just sent home, and yeah, the stoma nurses followed them up, but nobody else did. So as enhanced recovery nurses, we ideally like to ring patients the day after they go home, 1 or 2 days after they go home, see how they're getting on, and we use a very systemic assessment when we're talking to those patients. It's not just a quick phone call, hi, how are you, how's it going, you know, as part of it is bowel function, and for stoma patients as well, is how are they coping. Obviously our first question to the patient is, how are you feeling, you know, so we've got to know that patient during their admission, and they know we're going to contact them, they know they've got us as a support as well as the stoma team. So they have community stoma support, and they have us as well to contact. So not only do we follow them up with several phone calls as needed, we give them our contact number as well. And because we've built up that relationship, they feel very comfortable actually telephoning us if they've got any issues or problems, you know. And quite often we're asked basic stoma issues as well that we can then, if we can't answer them ourselves, being experienced colorectal nurses, we can back to the stoma team, and we can contact the stoma team and say, this patient's struggling a bit, can you give them a recall, you know, which doesn't happen often because they do have good community support from the stoma team. But yeah, there's that extra support because that patient's going home a lot sooner than they would otherwise have done. And we find that's really helpful for patients.
Okay, well, Deirdre, thank you so much once again for your insight. It's been fabulous. Thank you.
You're welcome. Thank you.
Okay, so thanks again, Deirdre, for such an insightful presentation. I hope you all agree there actually has been some very useful take-home messages which you may be able to apply within your own clinical practice. We will now move into a short live Q&A session, and Blanche will provide the translation. So over to you, Blanche.
Donc, Marie remercie Deirdre pour cette présentation enrichissante, très perspicace. Et maintenant, on va faire une petite session de questions en live. Donc, on a une première question de Laetitia qui est un peu abordée, mais on va reposer la question à Deirdre. La question de Laetitia, c'était qu'est-ce qui contient le kit de préparation, le kit d'essai pour le patient. So Deirdre, the question is what exactly is in the kit for the patient during the stay in the hospital? You mentioned it, but like the nurses would like to know exactly what is inside.
Oh, sorry, I think your microphone needs switched on.
That's fine. Sorry, had clicked on it, didn't work. Yeah, the practice pack, as we talked about with Marie there, it's pretty simple. Basically, the patient gets a prosthetic stoma, so it's just like a little piece of plastic that they're able to stick on their abdomen in the position that they're likely to have their stoma after surgery, so they know where it's going to be in relation to their clothing. And they get a stoma pouch as well, which there is got the size of the prosthesis that they can stick over the prosthesis.
OK. Merci. Thank you, Deirdre. Donc, elle a répondu que dans chaque petit kit, il y a juste une stomie en plastique qui correspond à quelque chose qu'ils vont recevoir eux-mêmes. Ils vont pouvoir le positionner sur le corps à peu près où ça va être après l'opération. Et ils vont avoir une poche aussi. Et comme ça, ils s'entraînent à poser le support et la poche jusqu'à ce qu'il soit opérationnel. Okay. We have another question from Marie. Okay. Donc, deuxième question qui vient de Marie, qui demande l'opinion sur la fréquence de 2 fois par jour de pédagogie sur la stomie durant le séjour à l'hôpital. Donc, je vais lui poser la question, est-ce que la fréquence est bien 2 fois par jour? Okay, so Deirdre, the next question is what's your opinion about twice daily teaching of stoma care while the patient is in the hospital?
I think if it was possible, that would be great. I don't believe it's maybe necessary for all patients. It depends on what kind of pathway they're on. And again, it depends on the service. We don't have weekend stoma teaching in our hospital, so we only have ward staff to support that. So I think it's difficult enough to provide once daily teaching from a specialist stoma nurse, let alone twice. But that is an exceptional thing to provide it twice daily. I think probably very difficult for most hospitals.
OK. Thank you, Deirdre. Donc, elle répond que dans le meilleur du monde, ce serait fabuleux d'avoir une pédagogie 2 fois par jour. Après, ça dépend la personne. Tout le monde n'a pas besoin de 2 fois par jour. C'est pas toujours nécessaire. En plus, quand ça arrive le week-end, il n'y a pas toujours les équipes présentes en fait dans l'établissement pour pouvoir faire ce travail 2 fois par jour. Mais une fois, c'est déjà bien. 2 fois, ce serait parfait. Alors, nous avons une autre question de Catherine qui demande l'expérience pour les patients en RAC qui ont leur intervention chirurgicale vers la fin de la semaine. Donc, ça arrive juste avant le week-end. Est-ce que ça impacte cet enseignement justement du STOMI? So, Deirdre, the next question is, in your experience regarding ERAS for patients who have had this surgery at the end of the week, does this impact a lot the patient and their teaching of the stoma care? It's like it goes with the question before, but
yeah,
is it difficult?
Very, very difficult. A lot of our lists are towards the end of the week. So we used to have 2 lists on a Thursday, 2 major lists on a Friday. And these patients, none of these patients would get seen by a specialist stoma nurse or an enhanced recovery nurse for 2 days. So they were being picked up by specialists on day 3. So our experience is, if you don't get in there on day 1 after the operation and establish the habits and the practice that they need to know going home, you are working on the back foot constantly. I don't know if that's an expression in French, but you're constantly playing yourself then and working to catch up. So that impacts on recovery and length of stay in every way.
Okay, thank you, Deirdre. Donc, elle a répondu que effectivement, il faut être présent le lendemain, tout de suite après l'opération, pour aider le patient à vivre cette amélioration. Et l'idéal, c'est de voir les interventions en début de semaine pour pouvoir, on ne va pas dire attaquer, mais pour pouvoir faire le travail nécessaire tout de suite. OK. Alors, j'ai une autre question de Claire qui demande la préhabilitation. On a parlé de préhabilitation et école de pédagogie post-opération. Et ils veulent savoir, donc elles veulent savoir un peu plus en détail sur ceci. So Deirdre, this question is just a bit more detail about the prehabilitation and the surgery schools in the post-operative context. If you could explain a little bit more about that.
So theoretically, a surgery school will be before the patient's operation. And this is all pre-COVID ideals. We were hoping for it to be a mandatory appointment for the patient, that they would have to attend this appointment before any major operation. And we would have short presentations from physiotherapists, enhanced recovery nurse teams, dietitians, and possibly stoma team if they felt there was any appropriate way to address a group of people, some of whom might not be having stomas. So that was our plan to implement just pre-COVID, and some hospitals in the UK have had great success with their surgery skills and positive data coming out of that the patient's outcomes are improved. Then if you want to translate that part, I'll come back to the prehab part then, maybe Blanche.
OK, thank you. Donc, la première partie de la réponse, c'est que pré-Covid, dans le meilleur des mondes, cette pédagogie doit se faire pré-opération où plusieurs spécialistes seront invités pour parler aux patients. Donc, ça peut aller de diététicienne à kinésithérapeute, mais tout ça, c'est l'idéal. Mais donc, ça n'a pas pu faire ça en ce moment. Donc, j'attends la deuxième partie de la réponse. Oh, Deirdre, the next part.
I will just add actually that the surgery school, we're looking at providing that digitally, potentially with a video.
OK. Merci.
Yeah.
Elle ajoute qu'ils aimeraient fournir toute cette pédagogie virtuellement à cause du Covid. Donc, c'est quand même une adaptation vers une virtuelle. OK, Deirdre.
Regarding prehab, the prehab part of the question, this is something again that we were about to implement just prior to COVID happening. One of our physiotherapists had identified a clinic where she was going to see patients for a targeted exercise program. Now, prehab can cover everything about preparing a patient for surgery, optimizing their medical conditions, giving them psychological information about their operation, but it mainly would be exercise, getting them fitter for their surgery, trying to support them through not smoking, alcohol, giving them a targeted exercise program, and also with nutrition as well, either putting on weight or reducing weight appropriately, whatever was appropriate to the patient. So that's the idea of prehab. Different hospitals support that in different ways, and some do it without any extra funding, but that requires, again, enthusiasm and buy-in of the whole team.
OK, thank you, Deirdre. Donc, Deirdre, elle expliquait le programme de réhabilitation, préhabilitation avant donc l'intervention. Donc, l'objectif, c'est quand même de préparer la personne pour être dans la meilleure de sa santé, si on peut dire, pour cette opération. Donc, ça peut aller d'une préparation au niveau de le régime, donc l'alcool. Ça peut être également un programme d'exercice pour que la personne soit en forme. Donc, ils invitent des kinésithérapeutes. Tout ce qui est physique peut être abordé. Donc, voilà. Donc, il y a tous ces différents acteurs qui peuvent aider la personne. Donc, chaque personne est différente. Voilà. Donc, pour l'instant, nous n'avons pas de questions.
Okay, is that all the questions then for Blanche?
Oui.
Oui.
Yes, all questions finished?
Okay, I think we've gone slightly past our time, but on behalf of Aiken, once again, Deirdre, I'd like to say a huge thank you to you and to everybody for joining us today. I've certainly learned a lot in relation to the whole physical recovery when patients go through enhanced recovery. Would you like to translate?
Yeah. Marie remercie Deirdre de nous avoir partagé toute son expérience sur cette vécu et cette richesse d'informations que nous pouvons partir avec aujourd'hui pour aider l'amélioration des patients post-opération.
However, as you know, I am very passionate about ensuring patients receive adequate psychological support, and having spoken to various nurses who are maybe discharged within 3 days of their operation, for me as a stomach care nurse, it's how can we ensure that they are fully supported when it comes to the whole psychological aspect.
Donc, Marie ajoute une dernière réflexion. Elle est passionnée par le soutien psychologique pour les patients et dans une fenêtre de 3 jours, un délai assez court pour le soutien de ces patients. Comment on peut améliorer la situation et rendre le contexte idéal pour le patient post-opération. Voilà.
Okay, well, thank you once again. We look forward to webinar 3, which will it will be facilitated by a French psychologist, and we will look at body image and self-esteem for our patients.
Voilà, donc nous vous remercions d'avoir participé, écouté. Le 3e webinaire, c'est par une psychologue toulousaine qui va aborder le sujet de l'image corporelle suite à un STOMI, enfin suite à une opération STOMI.